Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 35-year-old female who came to her ER with complaints of high-grade fever with chills and rigor associated with hematuria for the past 2 days, and she thereby went to a nearby hospital and was found to have a low hemoglobin of 5 and with thrombocytopenia came to our hospital for further management.
Yes.
And from the previous history, he was a case of ITP patient, sir.
Okay.
So on initial 10-second assessment, the patient was conscious and
ITP?
Sorry, idiopathic thrombocytopenia purpura.
What is ITP?
Immune.
Previously it was idiopathic. Now it is immune. We know that it is immune mediated destruction of platelet. Idiopathic means without any reason. Okay.
And on initial assessment, patient was conscious and oriented. And coming to the primary survey, airway was appearing patent and there was no pooling of secretion. In the breathing part, air entry was bilaterally equal and respiratory rate was 20 per minute with saturation of 100% maintaining in room air. In circulation, the pulse rate was 115 per minute and BP of 100/60. And disability wise, GCS was full score and pupil was bilaterally equally reacting. In exposure wise, she was afebrile, sir. And further, we went along with the adjusted survey, wherein which we took a VBG, sir. And VBG was showing an HB of 5.8. And there was no acid-base derangement in the VBG. And ECG was...
Can you comment about acid-base derangement in VBG? VBG is taken for electrolytes in our hospital. Can we...
Yes, we can comment, but it won't be the actual, it will be nearly, the bicarbonate will be, can derange, but can be, we can assess how much, if it is very low or something like that, we can assess.
Which condition we cannot judge the patient's clinical problem with VBG? We cannot. Which respiratory conditions we cannot. All metabolic conditions, VBG is more than enough. Okay, almost similar, but very minimal difference will be there. Negligible. Okay.
And ECG was showing sinus tachycardia. And further, sir, the history was, she was a known case of ITP and also a known case of autoimmune hemolytic anemia. And she was lost to follow up on, he was a regular follow up in our hospital and later lost follow up and having the history of fever with vomiting and hematuria with yellowish discoloration of eyes. And she went to nearby hospital and found us having a low hemoglobin and came to a hospital for further management. She was on TAP Visalon and TAP thyronum or hypothyroidism, Visalon 10 mg OD with thyronum of 50 mcg.
When will you give steroids when the patient is taking steroid tablet? What time in the day?
Morning.
Morning. Why not in the evening?
Sir, cortisol action.
Why we are giving steroids in ITP or hemolytic anemia? Why we are giving?
Sir, it's an immune mediated reaction.
Immunosuppressant. We are giving to suppress the immunity. But what happens if you give in the night time?
Action.
What happens? It suppresses the normal cortisol secretion from the brain. Okay. So that will completely shut down the normal secretion. So we don't want that. Which condition you give BD dose of steroid? BD means morning and evening.
Respiratory.
Then when there is cortisol deficiency, there you have to supplement it as a BD dose 2 times. But all anti-inflammatory dose should be single dose. Okay. Sometimes you can see BD Visalon is given for all these things. It is not correct. It will reduce the normal secretion of cortisol from in our body. But in a replacement dose, like cortisol is not produced, then BD dose is required. Okay. Suppose a cortisol deficiency patient admitted to ICU, how do you manage? What are the symptoms will be there in that patient?
Flushing, diarrhea.
Flushing. Hypotension. Hypotension is the most important problem. So diarrhea can be there in chronic. How do you manage that?
Steroid, IV steroid, high dose IV steroid should be given.
High dose.
Some-
High dose means what? These are the problems. These patients commonly come to emergency room, which is a common scenario where there is steroid, steroid deficiency coming into emergency room. Common scenarios. Patient who is on chronically on steroids like this, you are starting 10 milligram or 20 milligram BD for lifelong, for asthma or something unnecessarily. Suddenly patient discontinue that. They come with hypotension. How do you manage that?
to give steroids.
What steroid? At what dose?
1 mg per kg methylprednisolone in
Methylprednisolone, or which is a commonly used drug?
hydrocortisone.
Hydrocortisone. 200 milligram IV stat or 50 milligram IV 6 hourly, or continuous infusion of 200 milligram over 24 hours. Any mode you can give, but there you have to give at least BD or TID dose. Okay.
So here we did further we sent for the routine investigations, and in which we found that she was having a HB of 5.94 on lab with the platelet count of 17,000. And we sent for, as she was a known case of autoimmune hemolytic anemia with thrombocytopenia, we sent for the further evaluation including peripheral blood smear and Coombs test. And there in which
what will happen to the peripheral blood smear?
Peripheral blood smear can have acid
Hemolytic anemia. What will happen? Fragmented RBCs with various morphology is the most common finding. Okay. What are the other investigation you sent?
Coombs test.
Coombs test. What will happen to Coombs test in a autoimmune hemolytic anemia? Okay.
It will get positive. Coombs test direct positive. And indirect are there.
What are the other reasons for hemolytic anemia? If you take the reasons for hemolytic anemia, how do you classify it?
Idiopathic infections, then...
How do you classify? How do you classify?
Immune-mediated and
immune-mediated, non-immune-mediated, you can classify. Other than that, problem in the blood vessel. Problem of the covering of RBC, problem of the enzymes. Then one more is there, no? Problem of the hemoglobin as such. Okay. What are the problems of covering? Spherocytosis, electrocytosis, all these things. Hemoglobinopathies, sickle cell anemia, thalassemia. Enzyme defect, G6PD is the most common thing. Okay. Outside the RBC, extra corpuscular, outside the RBC. What are the causes?
That include
that is antibody mediated ITP, all DIC and all comes under that. That sepsis, all these things. What happens if malaria infects your body to RBCs?
Malaria when G6PD deficiency patients.
Malaria. What malaria does to RBC? Malaria also produces hemolysis. What it does? It enters inside the RBC and grow and rupture the RBC. That also produces hemolysis. What happens in the autoimmune hemolytic anemia?
Antibody mediated.
What happens?
Antibody direct against RBC cell membrane, and
what happens?
lysis occur.
It breaks. RBC go and attach to the RBC. The antibody go and attach to the RBC. When it goes through the spleen, what will happen?
Sequestration of
this will be detected as a foreign body in our system. So that will be destroyed. A foreign body in our system will be destroyed by the spleen. So splenic sequestration is the most important thing in hemolytic anemia. That happens. Okay, continue.
So here a direct and indirect Coombs test.
So Coombs test will be positive in immune-mediated destruction of RBCs. Rest all conditions it will be Coombs negative. Okay, so you can even divide into Coombs positive and Coombs negative hemolytic anemia. Okay.
And peripheral blood smear showed normocytic anemia with neutrophilic leukocytosis.
Okay.
Normocytic anemia, normochromic anemia with neutrophilic leukocytosis.
Okay.
and further we sent for ANA profile, and that's awaited, but ANA came 2+ in cytoplasmic test.
Okay. What happens in B12 deficiency anemia? That also hemolytic anemia.
That will be
Megaloblast. That will be destroyed in? That also will be
spleen.
destroyed in spleen. Okay. Okay.
And further we transfuse here with
So this patient is having a severe anemia. 5. And thrombocytopenia. What all things you take care in this patient in emergency?
Emergency, such she is having a low HB.
What is the lactate level in this patient? ABG?
ABG lactate came out to 0.9.
0.9. Is the patient is in failure or not here?
Not in failure.
She is not in failure because she is not having cardiac failure features. She is not having raised JVP. She is not having lactate. So she is not in failure, but she is having anemia. How do you treat it?
So I had to transfuse her with PRBC transfusion should be given. Followed by as she is already non-case of
why PRBC? Why not fresh blood or full blood?
It's
in our hospital we have PRBC, that's why we are transfusing PRBC. But some other hospital they have full blood and or fresh blood. So why we give PRBC? Where all you give PRBC? In all centers you don't get PRBC.
Autoimmune condition.
What is the indication for PRBC? Suppose you get a trauma case, acute trauma, blood loss coming to emergency room. What do you do? What is a preferred IV blood product?
Initially, as such.
Preferred. If available, that is a preferred. What is that? In a trauma case who is having acute bleeding, what is a preferred blood transfusion in that patient?
Whole blood.
Whole blood. Whole blood is always better in that type of condition. Here, why you cannot give whole blood, or you are not preferring whole blood transfusion?
Here the activity is against the RBC itself.
That is not the reason. What is the reason? Patient is already will be fluid overloaded if it is a chronic anemia. So fluid overloading will be there definitely. It is not an acute anemia. So if you are able to give RBCs, packs RBCs, that is always better. Okay. Because already fluid overloaded, you are giving fresh blood or whole blood, patient can further go to fluid overload, and patient go to cardiac failure. So you have to be very careful. In that condition, PRBs are the preferred transfusion, this one. Okay.
And
so how many PRBCs you give normally?
Here we transfuse with 2 pint PRBC initially.
Okay. 1 pint of PRBC can increase hemoglobin by 1%. 1 gram per cent.
1 gram. And as such for platelet, we never transfused. As such, she was.
What is the indication of blood transfusion here?
She was having a HB of 5 with a hemolysis and jaundice-like picture.
What are the indications for blood transfusion in emergency room?
Hypertension.
Is it an emergency here? No. It is not an emergency. Patient is fully preserved. Patient is having chronic anemia, say hemolytic anemia. Even if you transfuse, patient will have hemolytic anemia within 4 or 5 days without any treatment. If you are transfusing, it will be destroyed. So it is not at all an emergency. Only after starting the definitive treatment or correcting the hemolysis, then only you need to transfuse. What are the definitive indications of blood transfusion in emergency room?
Hypertension.
Hypertension is not a indication. Hypertension due to what?
Trauma.
Acute trauma, acute blood loss, it is an indicator. Then anemia causing heart failure or coronary artery disease, ischemic heart disease. Then symptoms of anemia. Suppose somebody is having severe breathlessness because of anemia, like 2 or 3 hemoglobin %, patient is in cardiac failure, So you have to give. Otherwise, it is not a definitive indication for acute transfusion. You can take time, you can admit the patient, you can evaluate, then only transfusion is required. What are the problems of blood transfusion?
Volume overload.
One is the most common thing is volume overload. Then
anaphylactic transfusion associated lung
Traco.
transfusion associated
Circulatory
circulatory overload.
overload. That is the same thing. Okay. Trally.
Lung injury, transfusion associated lung injury.
Is it common with packed cells or something else? Trally is common in blood transfusion or product transfusion?
Product transfusion.
Product transfusion. Okay. So trally, traco, we have to be very careful. The most common thing what we use the term is pulmonary edema. Whenever patient is having chronic anemia, when you give blood transfusion, there is a high chance of pulmonary edema. Okay. What electrolyte imbalance can be there in like packed cell transfusion?
Potassium.
Potassium, hyperkalemia. Okay. So that also can be there. Calcium.
Hypercalcium.
Hypercalcemia also can occur. But they are all clinically insignificant. Okay. So you have to be very careful when you are transfusing because you can have so many problems. So if it is required, only transfusion should be given. Suppose even if it is 5 in a hemolytic anemia, it is acceptable. As far as the patient is comfortable in your emergency room, there is no need to start transfusion because if the patient develops some fluid overload and breathlessness, you will not be able to tackle that issue in a busy emergency room. So it is not at all an emergency in a chronic anemia, especially like hemolytic anemia. Okay.
And we also started here on steroids.
So he has told about lactate. Now, what is importance of lactate?
Cardiac failure.
What is the importance? If tissues are not getting adequate oxygen, whether it is anemia or cardiac failure, whatever it is, lactate will be elevated. Here, lactate is completely normal. That means there is no problem in the circulation at all. She is well compensated for that amount of hemoglobin. So, there is no hurry in transfusion. Okay.
And steroids are given, sir. So,
how do you give steroid? This patient.
We see here given methylprednisolone 1 mg.
What is the indication for methylprednisolone 1 gram? It's 1 gram, not 1 mg.
That's pulse dosage.
This is 1 mg. 1 mg per kg. Prednisolone. Tablet.
Tablet.
Okay.
And that for to counteract with the immune reaction, we.
Okay, but she's having thrombocytopenia also.
Thrombocytopenia.
You treat that?
Is
there an indication for treating thrombocytopenia in this patient?
No.
Why? It is there. What is that? She is having hematuria. So it's an indication for treatment. Normally ITP patients, normally their like bleeding range may be somewhere around 5,000 or 6,000. Not like other patient who develops acute thrombocytopenia like in dengue. This will be around 3,000, 4,000, 5,000. Even that level they tolerate. But a patient is having clinical bleeding, we should not see the like level of platelet. We can transfuse if required. Which type of platelets you prefer in this patient?
Single donor platelet.
Always single donor platelet will be better in ITP. Okay. So that has to be given for this patient. Okay. So you can give platelet transfusion with the RBC transfusion, but only after starting steroids or steroid sparing agents we should start. Otherwise, whatever we give will be destroyed. Okay. So
in this condition, sir, she gave the history of hematuria. After reaching our hospital, she was not having hematuria.
Okay.
So we here never transfused, and after starting steroids on next day, her platelet count also improved to 26,000.
Okay.
And after 2 RBC transfusion, it's reached up to 8.4.
Okay. So steroid was started. How much steroid was started?
1 mg kg, 60 mg was given OD dose.
OD dose.
And further, we have given a hematology consultation also and sent for further workup for the SLE also. And
why SLE is important here? What is this syndrome called as autoimmune hemolytic anemia with autoimmune thrombocytopenia? What it is called as?
Evans syndrome.
Evans syndrome. What are the other reasons for these two entities?
SLE can.
SLE is the most important condition which can mimic Evans syndrome. It can produce both autoimmune hemolytic anemia and autoimmune thrombocytopenia. Steroids was started. What are the other treatment options?
We can start.
Suppose the patient is very sick and hemolysis is very severe, she is having anemia, severe thrombocytopenia, what other options are there?
IVIG can be tried.
IVIG can be tried,
Then we
especially when there is only thrombocytopenia.
can rituximab.
Before that, we can give rituximab is a costly drug. And rituximab takes some time. Steroids, bolus dose, that is pulse therapy. What are the pulse therapy options available? Either you can give methylprednisolone 1 gram, or you can give dexamethasone 40 milligram for an adult. If you compare the rate, dexamethasone will be very cheap, but the action will be almost similar or superior to methylprednisolone when you are giving dexamethasone. Okay, so dexamethasone or methylprednisolone should be given as bolus drug. What are the other options? Rituximab. Rituximab also can be tried initially, then alternate days or once in a week, once in a month, like that you can, this one. Okay, what are the other oral steroid sparing agents can be given here?
MMF can be tried. Tacrolimus, mycophenolate mofetil.
Okay, what is the dose?
500
milligram available is 500 milligram. TID or BD you can give. That can be continued.
And tacrolimus, azathioprine.
Azathioprine can be given. Okay, what is given for this patient?
Here, after starting with the steroids, we also advise her for rituximab, and we are planning on starting our rituximab.
Okay, what is the recent guideline say when you are starting steroid? What other drugs should be given along with that? Other drugs, thinking about the complications.
Lasix. Sorry, sir.
Lasix.
Vitamin.
These steroids are gastric irritants. So you have to give PPI or ranitidine, whatever it is. And steroids can produce osteoporosis. You have to give calcium, vitamin D. Okay, steroid can reduce your immunity. It can produce PCP, pneumonia. If you are taking a longer period, you give Bactrim-DS. Okay, these are the minimum things you have to give, and you have to follow up for the patient for hypertension and diabetes. How do steroid produce hypertension?
Vasoconstriction.
What is mineralocorticoid action of steroid? Mineralocorticoid action. What is that? Retention of water and salt. Water and sodium retention is the common problem which can produce hypertension. Okay, so when you are giving steroids, most of the patients after some time they develop hypertension. They also develop diabetes. How do they produce diabetes?
Hyperglycemia.
That is a counter-regulatory hormone that increases the sugar. What are the other side effects of steroid? Long-term side effects?
Immune suppression.
Immune suppression. Various infections are common. Then
weight gain.
Weight gain and buffalo hump, all these things. Then cataract of eyes. All these things can be there. So whenever patient is on chronic steroids, the patient coming to emergency room with acute hypotension, you should understand that patient has missed the doses of steroid. Then you have to give supplement hydrocortisone or methylprednisolone. Okay, that has to be given. Okay. Now what happened to this patient after some time?
After the transfusion, patients and started with the IV steroids. Patient's HP became stabilized, along with there was no further episodes of hematuria or platelet count was also gaining up, and later on we are awaiting with the ANA profile, and we are planning on discharging the patient with
what are the immediate side effects of blood transfusion? Immediate, that you are starting. It takes time.
Allergic reaction.
Fever, chills, rigors. What do you do when you have fever, chills, rigors?
We can stop the transfusion,
give paracetamol, give back the
rest of the transfusion.
And give back the blood. Okay, you may not try the same blood after that, because that again causes problem. If the patient is severely sick only, you may continue the same sample. Otherwise, if you have time, you better change the packet. Okay, then only you can do it. Okay, anything else you want to tell? Okay, so this is a hemolytic anemia, immune mediated hemolytic anemia and immune mediated thrombocytopenia. This is Ivan syndrome, and you have to rule out SLE in this patient. N is positive.
Na cytoplasmic 2+ positive.
Okay. So DSDN has not.
Wait.
Okay. Thank you.